Inside busy hospitals, medical teams prioritize the most obvious ailments. This allows kidney disease to operate as a silent illness, leading to frequent misdiagnosis. This creates a difficult choice for the patient: accept the standard high-probability diagnosis or take on the friction of advocating for specialized renal testing. This quadrant chart illustrates the misdirection. When severity is high but visibility is low, kidney disease remains hidden. While doctors focus on visible symptoms, the actual renal issue stays locked in this invisible danger zone. Identifying 3 markers pulls it into a visible, actionable quadrant. We are mapping 3 strict scenarios where common physical quirks point toward renal decline, providing the exact criteria needed to trigger a specialist referral. Early detection provides the data needed to justify a course correction when standard medical advice proves insufficient to resolve the underlying problem. The first scenario begins with the sensation of fluid visibly expanding the tissue in your lower extremities. This is edema. When you present with this level of swelling, standard medical protocol prioritizes checking the heart and liver first. Physicians must rule out immediate life-threatening causes, like heart failure or deep vein blood clots, before looking elsewhere. This decision tree shows where the process often stalls. Once the heart and liver are cleared, many consider the work complete. But when kidneys leak protein, the body retains salt and water, creating the same swelling. This requires a specific shift toward renal panels. Additional indicators that the swelling is kidney-related include urine the color of tea or dark cola and sudden spikes in blood pressure. If your heart and liver are cleared but the edema remains, you must request the specific lab work needed to evaluate kidney function. The second scenario involves patients caught in a cycle of recurring urinary tract infections. In many clinics, a quick urine dipstick showing blood or protein triggers an immediate antibiotic prescription. The flaw in this cycle is treating the inflammation as an infection without waiting for the lab to confirm if bacteria are actually present. This logic path isolates the critical red flag. Did the formal urine culture actually grow bacteria? If negative, you have a sterile UTI. This means the blood and protein come from structural kidney damage, not an external bug. Chronic blood or protein in the urine that lacks an infectious cause represents an underlying renal problem that antibiotics cannot fix. To break this cycle, you must challenge the assumption of infection and demand to see the formal lab culture results. Persistent symptoms paired with negative cultures are the definitive signal that you need a referral to a nephrologist. The third scenario relies on your own daily observation of physical waste. The primary marker is urine that appears abnormally bubbly, creating a thick foam that lingers on the water surface. Splash bubbles created by high-velocity impact dissipate almost immediately. Pathological foam is stable and persistent, indicating that damaged filters are leaking large amounts of protein into the waste stream. This decision tree helps separate benign bubbles from medical alerts. If the foam is persistent and accompanied by secondary symptoms, the risk level increases significantly. When visual foam is paired with unexplained fatigue or dark urine, it creates a definitive trigger for immediate lab work. Recognizing this visual signal early allows for medical intervention that can slow the underlying disease before it leads to systemic organ failure. Tracking these visual changes is a zero-cost method for monitoring your long-term kidney health. Because modern medicine relies on high-speed pattern recognition, anomalies that don't fit the standard mold are easily overlooked. This patient action scorecard summarizes the specific points where you must push back against standard medical assumptions. If you are experiencing unexplained swelling or recurring sterile UTIs, the standard assumption has failed. You must demand an evaluation by a nephrologist. To monitor your function effectively, ensure your medical records include a recent blood panel, a urine dipstick, and a formal urine culture. Self-advocacy can feel socially uncomfortable or even confrontational in a clinical setting. However, that brief social friction is a small price to pay compared to the permanent physical cost of missing a window for treatment. The ultimate return on investment for asking a direct question and requesting a urine test is the preservation of your long-term health and independence.